All right. So I'm from New Zealand. I live in Auckland. I've been there for 25 years. I work in North Shore Hospital, which you can see there. Uh, uh, Basically, we're talking about acute coronary syndrome, and enough has been talked about it. But the basic pathophysiology is that you get a plaque rupture. You either completely block the coronary artery with complete thrombotic occlusion leading to STEMI, or you get partial occlusion with stuttering MI, which is non-STEMI. Uh, the STEMI obviously by default, comes to a high risk procedure condition, which most of the time needs acute intervention. Non-STEMI is slightly different beast. However, high risk non-STEMI patients benefit from early invasive procedure as well. Now, risk assessment, this is a broad slide. I'm sorry for being overcrowded here, but this is what you really look at in a nutshell. You assess ischemic risk of the patient, then you balance it out against the bleeding risk, and you've seen that case that Professor Malik showed in the live case. And then you assess hemodynamics and contrast-related issues, vasculopathy, and all the other lots, and you come to a conclusion if a patient should go to the cath lab immediately or not. There are risk scores to stratify acute coronary syndrome patients, and mainly the TIMI score and the GRESS scores are used. This is mainly to highlight the importance, how sick the patient is, and how soon the intervention is needed. GRESS score has good validity. Any score over 140 with a non-STEMI patient should go to the cath lab within 2 hours as per the guideline recommendations. And we know early versus delayed intervention. Early intervention translates into better outcome. And it's both in STEMI patients and high-risk non-STEMI patients. Not so much clear-cut in low-risk interventions, basically because they're at low risk. Early intervention in high-risk non-STEMI patients, I just pointed out, benefit is in high-risk patients. We all know about this pathway. Basically, it's in the guideline. I just wanted to highlight at the bottom of the figure here, you see that there is the total ischemic time is very much dependent on two issues. One is how soon a patient who's affected asks for first medical contact, and the system delay subsequent to that. We have done a lot of work over the years on the system delay and achieved the best we can in most places. You either do early fibrinolysis if there's no primary PCI options available, or if it's not within the 3 hours, and then you can consider pharmacoinvasive approach in failed cases, or you do primary PCI. What we don't have a lot of work done yet, and we haven't got enough control on, is the patient level delay, which is on the left side. And the guidelines say that primary PCI is a class 1 indication for patients who present early within the first 12 hours. If it's past 12 hours, then data gets a bit murky, but still it is beneficial in patients who gets hemodynamic, electrical instability, and if they have ongoing ischemic symptoms. Now, in the pandemic era, it is very timely, so I thought I'll talk about it. We have seen a delay in STEMI presentation in hospitals, and you can postulate a lot of hypotheses, and this has been seen in North America, Europe, and all the other places as well. What we have noticed is because of system overload, there has been delay in healthcare delivery, but also there has been delay at the patient level because of the general anxiety about presenting to hospital with the fear of contracting COVID. This colleagues in St. George's Hospital in UK has elegantly showed that their STEMI numbers have come down during the height of the pandemic, and that translated in more patients presented later than 4 hours. And obviously, it resulted in adverse outcome in terms of LV dysfunction and greater in-hospital mortality. The Chinese experience also shows the same. This slide shows comparison between Hubei patients and non-Hubei patients, and you can see on the right side that the thrombolysis there was more thrombolysis at the cost of less primary PCI at the height of pandemic. We saw a similar trend in New Zealand. This map plot shows on the left side time to fibrinolysis in regions where fibrinolysis is still practiced. And we failed to achieve more than 85% target within 90 minutes and 60 minutes. And same was the case for primary PCI. I just wanted to highlight that, and this was probably because patients presented late. And I thought I would show a case whereby we thought a delay in presentation led to an adverse outcome. My patient is a 59-year-old man from Waiheke Island, which is northeast of Auckland City. We are not sure of the duration of chest pain because he didn't call the ambulance until he started feeling faint. When the ambulance arrived, there was gross anterior elevation on ECG that was transmitted across. Immediately, an air ambulance was activated and the patient was in impending shock as per the ambulance notes. I'm sorry, I don't have the ECG available, but you've seen enough STEMI ECGs today, I think. So we activated the cath lab. Unfortunately, the patient went into VF arrest as he arrived in ED, had 2 DC shocks converted into a pulseless electrical activity. He was intubated promptly, ventilated, and mechanical CPR was initiated. Dr. Dagubati already mentioned about the Lucas device. This is how it looks. Quite effective in transporting in resuscitation patients to the cath lab. There are things that you learn during fellowship that you shouldn't do. And this probably is one of them because the pH of the patient was only 6.9. But this guy did not have any prior medical contact. In other words, he was completely well until that day. So we decided to take him to the cath lab. I just wanted to show you how it is to deal with a cardiac arrest patient during active resuscitation. As you can see, he had a complete thrombotic occlusion of the left main artery. We did do a thrombus aspiration with thrombostat catheter, and that restored flow. However, he did not revive his circulation. Carried on. I initially thought we'd put a short left main stent. A 4x12 Synergy stent was deployed, and you can see there was flow to the circumflex got cut off. The LAD had flow. It is a very challenging situation to deal with left main occlusion in patients who are actively being resuscitated mechanically, and I just wanted to highlight that here. So after the stenting, when the circumflex got cut off, we rewired the circumflex and put a stent in circumflex, a 3x16 Synergy here, and then we promptly stented the LAD in a trouser leg fashion. And we finished off with kissing balloon inflation and proximal optimization of the left main stent. And there was flow, but you can see these people are inherently very thrombogenic. So despite Ivar's confirmation, there was good coronary patency restoration. There was thrombus, and for the whole period of time, we did not regain spontaneous circulation in this patient. So we initially had plans for balloon pump. However, after a heart team meeting, we decided enough was enough and we should stop it here. So we called off resuscitation at that point. So our case tells us that we think that this patient had delay in seeking medical attention, and pandemic may have influenced that. Obviously, that led to progression to cardiogenic shock and eventual cardiac arrest. We failed to achieve resuscitation, spontaneous circulation despite restoration of coronary patency. Likely unrecoverable myocardial damage. I just wanted to show this slide that as the STEMI presentation gets delayed, patient tends to present sicker and the benefit gets blurred with time. Now, the guidelines have recommendations about out-of-hospital arrest patients who are resuscitated. So thereby, early intervention in survived cardiac arrest patients. We have insufficient data on restoration of coronary patency and its benefit in actively resuscitating patients. I think revival of spontaneous circulation is the holy grail here, and progressive shock obviously complicates matters. Extracorporeal CPR has a very niche role in certain situations like this, whereby conventional ALS fails and you try it is beneficial to support you to offer adjunctive therapy like intervention. Tailing on Dr. Dugabati's talk, there is a temporal trend on cardiovascular outcome and out-of-hospital cardiac arrest, despite active intervention early, shows benefit in cardiac side, but the general trend in neurological recovery remains poor. And I picked this slide from this EuroCity PCR meeting this year in the resuscitation sessions. You see, this gives you an idea. Most people with cardiogenic shock and cardiac arrest dies of neurological death, really. If we can suss out patients from the mix of neurological problem and cardiovascular shock to those green ones who we can offer benefit to, then that would lead to positive outcome. And this has resulted in the importance of identifying some prediction tools whereby we can say that we can have some assessment about neurological outcome from cardiac arrest. And the European Cardiac Arrest Registry has given us some light onto that and suggested the Miracle 2 score, which includes assessment of any missed arrest, if there's any non-shockable rhythm, if there's any non-reactivity of the pupil. Age carries heavily, particularly if it's over 83 points, and changing rhythm, low pH, and epinephrine use. Now, any score more than 3 usually suggests bad neurological outcome. And if you look at the right side panel, there is a small window of opportunity of patients with Miracle 2 score of less than 4, with a sky shock stage between B to basically D. I wouldn't say E because E is irreversible shock. Now, I will skip that slide, but Dr. Dugabati has mentioned about sky shock stages, but you can see on the right side panel, mortality goes up as the stage of shock advances, and it's almost 50%. I'll skip this, but LV support considerations are balloon pump. A lot's been talked about Impella and VA ECMO. I just wanted to show this slide here. The EuroShock trial looked at implementation of VA ECMO early in patients who survive cardiac arrest who's in bad cardiogenic shock. The benefit numerically was lower, however, the numbers was not enough. I just wanted to highlight the red writings here. The main reason, the trial actually screened 333 patients, but only 35 was enrolled. So that shows the inherent difficulty in recruiting patients. And these people tend to have inherent thrombogenicity, and the stent occlusion thrombosis rate is very high, more than 20%. So even if you treat the infarct-related artery, likelihood of stent thrombosis is high. So there are some options here which you can do to protect that, minimize that. I would like to conclude by saying that risk assessment in ACS is crucial for timely intervention. Early intervention saves lives. Cardiac arrest is a special group of ACS patients where early success of resuscitation is the main prognosticator. However, we have limited experience in extracorporeal CPR and pursuing acute coronary intervention. Thank you.
Thank you, Dr. Ali.